the test to see what's the epidemiology of these factors that leads to.
I think I might be wrong. Oh, sorry.
After having talked about all those things, I think it does make sense to see what we can do to prevent oral cancer from getting started. And one way to prevent that is screening. But the question is, does the screening work for oral cancer? These are the criteria for screening for any disease. According to Center for Disease Control, these are the criteria should be fulfilled in order to make it worthwhile for you to do a screening. For example, you should have an identifiable, diagnosable disease that is an important health problem. Well, oral cancer is a big problem in terms of mortality, but it's not a very common disease. Availability of accepted treatment, we do have that. A recognizable latent or early symptomatic state, yes. Leukoplakia, erythroplakia, these are early stage, but really by looking at it, you cannot tell. Adequate understanding of the natural history of disease.
Should that actually say a recognizable latent or early asymptomatic state?
Oh, maybe that's asymptomatic. Yeah, I have to check that, I can't remember. Adequate understanding of the natural history of the disease, like you know how it evolves. A simple, cost-effective, reliable test with acceptable false positive and false negative rates. So these are all the criteria. And when they did the analysis, they found out that the oral cancer really does not fit all the criteria. We really don't have anything that is approved by FDA as a screening test, for example. If you want to know something is bad or not, you have to do a biopsy. You know, and when you are doing mass screening, how easy it is to do, biopsy right there and then. So basically, we rely on doing the oral cancer exam, and oral cancer exam starts by doing the extraoral evaluation, which is, checking for the lymph nodes extraorally, submandibular, submental, looking at the extraoral aspect of the lip, looking at the labial mucosa, top and the bottom, looking at the buccal mucosa, right and left, looking at the gum, just cursory. This is the soft tissue exam. The dental exam is much more extensive, but just the soft tissue exam. Starting from the upper right, going to upper left, lower right, and then do the same thing on the inside gum. Looking at the dorsal aspect of the tongue, lateral aspect of the tongue, you have to have gauze, pull it to the side, and actually visualize it, and then touch it. And do the same thing on the other side. And you're looking for the red spots, white spots, things that are unusual. That doesn't mean they are cancer. That's the difficulty. That means something is abnormal. But how would you know that it's dysplastic pre-cancer, or is it tongue biting or tongue chewing? You don't know that without doing a biopsy. And then looking at underneath surface of the tongue, this is ventral, looking at the floor of the mouth, roof of the mouth, and I think this ran out of the battery. Looking at the back of the mouth, this is where the oropharyngeal area is. You look at the anterior and posterior tonsillar pillar, the uvula, posterior pharyngeal wall. And then the last stage is to put your gloved finger inside and outside and just walk it and see if you feel any induration, any pain, any lump, anything that the patient reports or you can actually feel. Now, oral cancer screening, as I mentioned, we have attempted it and we have been doing it actually for 20 years at the dental school here. But have we found any oral cancer? I'll tell you, in the past 20 years that I've been involved with, we have not found a single oral cancer. Because it's an uncommon problem, and the focus of the oral cancer screening should not be to find oral cancer. It should be to find pre-cancer, because that's where you can do something about. Because once oral cancer is already advanced enough that it's easily recognizable. And they have found that there is poor detection rate during routine screening, and the true sensitivity, specificity, positive predictive value of the clinical oral exam compared to gold standard, which is the biopsy, is not known. We don't know. But that's the best thing we have right now, doing the clinical exam. So we don't have any adjunct. When you get out in practice, you pick up this dental journal and you see that they are always advertising about the adjunct techniques for oral cancer detection. Some of them rely on brush tests, some of them rely on light fluorescence, some of them rely on special rinses that colors the mucosa, but none of these tests are actually reliable enough to help you say for sure this is something bad and it needs to be biopsied right there and then. So because of these factors, we are at a little bit of a disadvantage. And in fact, I still teach those adjunct techniques in third year to the students because I want them to be able to know what's out there so they don't get fooled by the advertisement. Some of them have some benefit, but they are not, foolproof, and that is important to realize. This is the study that was published in the American Dental Association journal in 2017, and they said that all suspicious lesions should be biopsied. So essentially, our gold standard is the biopsy. Nothing else comes close to it. You cannot really tell with the brush test or with the rinse test or with the light test if this is cancer or not until you take a piece of tissue and put it under the microscope. None of the available adjuncts show sufficient diagnostic test accuracy to support their routine use as a triage tool for lesion evaluation. Because this, reps come to your office and they want to sell you something that is like $2,000, and they always tell you, well, this would be good, this is a good practice builder. You can tell your patients that they do oral cancer screening exam using this device. You can charge the patient for it. And I'm not putting these devices down. We actually have used every single one of them in the oral medicine clinic at different point in time, but I never relied on it 100%. And I personally think the way we use it in our clinic is different than the way the general practitioner does it in their office. We are a tertiary care center. We get referrals from private practitioners for a patient who has a lesion. So I already know that, and I use it differently compared to somebody who doesn't see these cases all the time, and they want to apply it. There are false positive, false negative, so therefore there are more risk associated with using it in a general practice than using it in a specialized practice like we do it. But even I don't rely on this. Biopsy is the ultimate goal. Now, the only test that the study kind of supported it little bit is the brush test, but that's only as a bridge. Like for example, your patient has hemophilia, or has liver disease, or has cirrhosis, and they have bleeding issues, you cannot do the biopsy. Just for now, let's do the brush test, get some preliminary data, and later on, we do the biopsy. Or the patient is scared of getting a biopsy, let's do the brush, get some data, and then do the biopsy. So it does not preclude doing a biopsy, it just buys some time for it. But this is basically the status that we have right now. Now, having said that, I am advocating for oral cancer screening, even though it's not very productive in terms of catching oral cancer. But we always find lesions. Some of them are reactive, some of them look precancerous, and we still have to schedule the patient to come back to see what it is. But most importantly, we do that because it raises awareness. It makes the patient aware that there is such a thing as oral cancer, and these are the risk factors for it. So when we have oral cancer screening, we have people coming from to provide tobacco cessation. They have flyers on their table. They educate the patient about risk factors. At the same time, we have people who measure the blood pressure, people who test the blood glucose. So we do like a whole lot of health awareness in general, and at the same time we do oral cancer screening too. And the benefit of that is good. Now, if you have a group of individuals that are high risk, your likelihood of actually catching something is much higher. For example, if you have people coming from substance abuse centers, which we actually have done. In the past 10 years, we have had people busting from Integrity House, which is just a few miles down the road, and this is a substance abuse treatment center. These are people who are like a halfway house that drug addicts go there until they find, their way. They beat the habit, they're trained some skills so they can get a job, and then they are released to the society. And we had a very good relationship with Integrity House, and at their own cost, they would bus their clients to come to our center every year in May, and we would do oral cancer screening. And every year we found something. They weren't cancerous, but they looked suspicious. And I always arranged for a follow-up. They would come at a later time, and we would do the gold standard, which is the biopsy, to make sure that they are diagnosed in a timely manner. So if you have smokers, alcoholics, elderly, low socioeconomic group, anybody with prior history of cancer, these are high-risk groups. Your likelihood of success as doing mass screening is better than just offering it to anybody under the sun. So targeted screening is one strategy. Now, right now we are relying on visual exam, the same way that I talked to you about, doing the extraoral, then going to inside of the mouth, and if you find something, you either do the biopsy yourself or refer them for further evaluation. Now, one thing to keep in mind is that some patients go to the physician. Physicians look at, everywhere, but when it comes to the mouth, they ask the patient to say, they just look at the uvula. They basically dismiss buccal mucosa, ventral tongue, floor of the mouth, everything that I showed you earlier. And those are the areas that is the high risk for oral cavity cancer. So one of the things that I do a lot of lectures, especially for medical providers, is that I teach them how to examine the mouth and don't disregard it, don't poo-poo it, and they don't really pay much attention to it. They just go to the uvula as if there is nothing else in between. I show them the examples of lesions that are located in their nooks and crannies, and they can miss it. The patient can leave their office thinking that everything is okay. So if we train the non-dental providers, they can also be helpful in catching things early and send them to the right clinician to get treated. Many Americans do not see a dentist on a regular basis because of lack of insurance, but they go to the physician. Blacks, regardless of the socioeconomic status, they did some study and they found out, I don't know if this still holds true, but that in that particular study, that even though they had the insurance, they tended to go to a physician rather than to the dentist. So and one other thing that they have found out that is when you receive a referral from a dentist, the cancer is in an earlier stage. But when you receive a referral from a medical provider, usually they pick up late cancer. Why? Because they don't look in the mouth as often. They cannot pick things up that are early on, like subtle changes. But we are more familiar because that's all we do. This is our area of expertise. So dental professionals or oral physicians, we spend 4 years in one anatomical region. We are supposed to be better. Now, this is a story that I'd like to share with you. This is not a patient that came to my office. This is something that was on the internet and I just transcribed it. This was a patient who wanted to get dental bleaching. I know you know what that is. A patient who wanted to have whiter teeth. So she received a coupon in the mail from the dental office. Don't get me started on that. I think that's a terrible thing when they send coupons as if they're plumbers. But the patient got the coupon and went to the dentist, and it was $99 to get your teeth cleaned, to get your teeth whitened. And the dentist did the exam and started to do the whitening and saw a sore and told the patient, you have a sore there. And the patient said, it's nothing, I probably bit my tongue. And the dentist finished doing the whitening, and the patient left the office. He did not facilitate referral. The patient later on, that lesion progressed. She went maybe, I don't know how much longer down the road, but went to an oral surgeon, a biopsy was done, and it was cancer. And what happened is that the dentist was sued that she had seen these things early on, but she had not facilitated the referral. This excerpt was written by a lawyer in order to train the dentist. And her, learning lesson was document, and do your oral cancer exam, even if they are coming for a $99 special. And that doesn't exclude. I mean, you should, at a minimum, give a referral to the patient and write down in your chart that you did that. And that again doesn't absolve you, but that's better than not doing anything because you have no leg to stand on. And by the way, the patient got the result, the decision was in favor of the patient, not the dentist. So what are we screening for? We are screening for white spot, red spot. Like here, there is very subtle change. You see that white thing there? Is that trauma to the tongue or is it precancer? We don't know. But we see that a lot in the mouth. You know, and clinical exam is important, but it doesn't really give you, you know, the answer. You have to dry the mucosa, spend a little bit of time, have good lighting, patient has to be reclined in the proper position, so you can see the mucosal abnormality, but that doesn't tell you what it is. You still have to do a biopsy. Like this one, this is more obvious. In a ventral tongue, there is no source of irritation. This was mild dysplasia based on biopsy. And sometimes we wait a couple of weeks if we think it's caused by trauma after we have addressed the source. If it's still there, then we do the biopsy. We may not do it in the first visit. But here is the on the inner commissure of the mouth. The first thing that I thought was that the patient is doing lip chewing, and I have seen people that constantly traumatize their cheek, and that's what my impression was. But because the patient was HIV positive, I always am more aggressive and more vigilant in that patient population, and we did the biopsy and it was severe dysplasia. This one is a red area in the ventral aspect of the tongue. Now, is it erythroleucoplakia, which is precancer, or is it something called geographic tongue, which is a benign finding and really multiple in number? It's very unusual appearance even for geographic tongue, but that's exactly what it was. This patient had multiple lesions like that in other areas of the mouth. That's how I made the clinical diagnosis. We did not make a biopsy. But if it was solitary, I would have. How about this? This is a red and white patch on the lateral border of the tongue, starting to become symptomatic. Burning, could this be candidal infection? Could this be irritation? Could it be rubbing against the tissue? Could it be precancer? All of those are on the differential. We did the biopsy, and this was something called lichen planus. I mentioned that earlier. It's a mucocutaneous disease. Now, if you see lichen planus, you usually expect to see it in multiple sites rather than just one area, but I can't remember if this patient had it anywhere else. This one is on the palate. You can see there is some red area on the palatal aspect with some white patches. The patient was very adamant not to get a biopsy done. I called multiple times to encourage her to come back and do a punch biopsy. She didn't want to have anything done. And the last time she hung up on me, and I wrote down in the chart that the patient hung up on me. So it's important because I did try. You know, every time you contact the patient, you write your own note. And because I had a feeling this is going to evolve into something else, and I want to protect myself. How about this one? This is very interesting. Can you see the lesion? Exactly. See the redness? The color of the tissue is changing. That's pink, but all of a sudden you have some red area. And that red area continues into the palate. This does not look that serious, honestly. When I saw it, I thought some redness. I didn't think of candida because it was so localized, but it was, you know, fairly localized, starting from the mesial of that tooth and going all the way to the tuberosity. And the patient said, when I brush, if my toothbrush accidentally passes by the last tooth and touches that area, I get some bleeding. And that was the only complaint she had. So we did a biopsy. I was very surprised that it came back as a squamous cell carcinoma. Even though it really doesn't look like a cauliflower growing, but it was. And it actually was invasive into the bone. And the surgeon removed some of the bone, so the patient ended up with a defect because they had to treat the disease. How about the red area in the uvula? Could it be a patient like me who has a cold and coughing too much? Yeah, could be. Could it be because the patient is too hungry and ate a hot soup and burned themselves? Yeah, that's another possibility. Or could it be erythroplakia, which is a precancerous condition? So I wait a couple of weeks, especially if the patient has a cold or a reason for it. If it's still there, you know, I would biopsy that because there is enough justification. That red is not supposed to be there. Oh, but this is also red. This is in the upper pharynx, like in the soft palate, and this was the only area that the patient had. asymptomatic, incidental finding. I think the patient came to get a denture made. They put their trust in you. They think you're going to make them a good denture. But in this case, the patient's life was saved because the student noticed that red area, came and asked me to come and do a consult. I said, this is not normal. I would have done a biopsy, but that area is very hard to reach, and if I want to do a biopsy, I may not be able to stop the bleeding, especially if the patient has a very strong gag reflex. You want to suture it up, it's difficult. So I said, I'm going to send it to the surgeon. They did the biopsy, and it was a squamous cell carcinoma. So in the process of making a denture, the patient found they have a cancer. And actually, the cancer was in the throat. This was the superior extension of it. So, advantage of the oral cancer screening is, as I mentioned, increasing the awareness, and especially patients who are of low socioeconomic group may not have other places to go. And a lot of people who come to our oral cancer screening are people who don't have anywhere else to go and say, well, I take the advantage of going there. Okay, so what are we supposed to do? I think one of your colleagues asked me, so after all this discussion, what then? This is what you have to do. You need to communicate with your patient. And your communication is raising awareness about oral cancer. As you're talking to them, as you're doing the clinical exam, they're sitting there with their mouth open, they cannot do anything but to listen. So you can just talk to them. You can just tell them, by the way, I'm going to screen you for oral cancer. Did you know what causes it? They say, like that. And you just keep saying, talk to them. It's not funny. That's what I do with my patients. You talk about tobacco, alcohol. You can have, brochures in your office that you can give to them. Assess the risk profile. If somebody says I'm a smoker or a drinker, you can educate them about that and encourage them to stop. Over the past few months, I had two patients that one of them was a pipe smoker, and I saw him at faculty practice. His roof of the mouth had nicotinic stomatitis that I have never seen that bad. I mean, it was phenomenal. I am using it for lectures now. That's so classic. And he had white patches on the buccal mucosa. For 55 years, he's been smoking pipe. And he fills his pipe multiple times during the day. And imagine that heat and that tobacco smoke, what does it do to the tissue? I did biopsy, all of them were dysplastic. And I told him, when I did the biopsy, I told him, I hope this doesn't come back as cancer. And he really became nervous, and he knew I had these things, and he had delayed coming. But when he came back to get the report, the vision had improved, and he told me that after 55 years, he stopped smoking. That was amazing. And he went cold turkey. He did not go on Chantix or anything like that. There is nothing wrong with that. I think if anything you can do to help yourself, like a crutch, temporarily, that's okay. But he went cold turkey, and I could see the benefit of that. And nothing is better than feeling good that you had a role in it. I tried not to scare him, but I did. But it worked. It worked, and I told him that you're lucky that it's dysplastic and it's not cancer. But I sent him to have the lesions removed, and I said that if you stop now, hopefully you will protect your tissue from having the same lesion later. If they are ready to quit, you can teach them, you can help them. Some of us can get training. I am a tobacco treatment specialist. I have license for it, but not everybody has time for it. You can refer them to other people to do it. Inquire about HPV vaccination. It's important, especially in younger people, adolescents. When they come to your office, ask the parent, has this kid been vaccinated? And if they're not, you can educate them. Now, HPV vaccination is something that is endorsed by American Dental Association. There are lots of pamphlets you can put in the office as they're waiting to be seen. They can read it, and hopefully they choose to vaccinate their kids. And there is benefit to that because the current vaccine, the newest generation, protects against HPV 16 and 18 that causes the cervical cancer. And because the same strain causes oral cancer, you're automatically protected. And it also protects against warts, which are unsightly and ugly, and they are very highly transmissible. So you are protecting the patients against non-carcinogenic as well as carcinogenic strains of HPV. Encourage UV protection for lower lip because of the sun exposure, patients are at risk for oral cancer on the lip. Encourage fruits and vegetables. Again, we don't have that much data, but there is no harm in it. I know that this benefits for colorectal cancer, and mouth is a continuation of the same tube, and there's some benefit to that. repeat this again and again every time they come, and hopefully they remember it. Believe me, your patients forget everything you say the minute they step out. But if you keep repeating it, hopefully some of it sinks in. For oropharyngeal cancer, remember, as dentists, we don't have a scope, we cannot reach that far back. But you can ask the patient about symptoms. Have you had persistent sore throat? Have you had voice changes? Do you feel a lump in your throat? Have you felt a lump in your neck? These are things that could indicate oropharyngeal cancer. Doesn't mean any of this means cancer, but if you have multiple signs and symptoms, it's time to see the ENT. So American Dental Association, this is the position statement that I just put in to the lecture this morning, adopts the position that HPV vaccination, this was developed in 2018 last year, as recommended by the CDC Advisory Committee on Immunization Practices, is a safe and effective intervention to decrease the burden of oral and oropharyngeal HPV infection. And also, be it resolved that ADA urges dentists, as well as local and state dental societies, to support use and administration of HPV vaccine. In fact, in Oregon, last week, they approved dentists delivering HPV vaccine. That's the first state in United States that dentist is licensed, like is allowed with training to administer vaccines, including HPV, all vaccines. They can do flu shots and other things too, because we are a healthcare provider. If a nurse can do it, why can't I? We can do it. We just have to get the training. Be it resolved that it encourages appropriate external agencies to support research to improve understanding of the natural history of HPV infection, transmission risk, screening, and testing. We are not approved to do it in New Jersey yet. We got approved a few years ago to do diabetes screening with the hemoglobin A1C, which will be starting here as of August. But this is on the way. Hopefully we'll get approval for that in this state too. And these are some of the brochures. Maybe I'll send you this because I just put it this morning. So these are the brochures that ADA has developed that dentists can pass it out to their patients while you're waiting. Get them facts about mouth and throat cancer. The mouth is the oral cavity, throat is the oropharyngeal. And then oral health and the HPV vaccine, and they have a bunch of young people. Because that's the time they should get it. Once they get it, once they get involved with sexual activity and get infected, then there is no point. They should do it while they have the window of opportunity. And this is in Spanish, this is in English. Exploring Mars is on her to-do list. Is protecting her from cancer on yours? That's to educate the parents that they should take a proactive role to get their kids vaccinated against this. And this is another one, showing the dentist and say cancer prevention through HPV vaccination. So hopefully this is on the way. You'll get, I think you are the first group that is learning about HPV vaccination in the dental office. I teach about HIV testing and everything, but this is the first class that we're hearing and hear more from me about HPV vaccination. Because role of dentistry is changing. We are not just going to be doing filling. We are going to do more than that. We are going to be into holistic care, and we are going to, take care of the oral health and screen for certain diseases that we have a role in, such as this. Okay, finally, examination. Inspect the patient's oral cavity, do the extraoral and intraoral, inform patients when you're doing it. That is sad that you're doing the exam, but you're not telling the patient you're doing it, because they have done surveys and asked the patient, has your dentist done oral cancer exam? And a lot of patients say, no, my dentist never does that. But the dentists are doing it, they are trained to do it. Majority of us are doing it, but they are not telling the patient. It's very important as you're about to do it, say, Mrs. Jones, I'm just going to do oral cancer exam for you. That makes them think that, and then you can educate them at the same time. Because they leave your office, they do nothing. Document anything you find, signs and symptoms. If there is something that you think is odd or abnormal, bring them back in a couple of weeks after you have addressed the cause. Tell them to eat on this side, get rid of the sharp edges, and give them time for the tissue to heal. And if it's not improved, you have to do a biopsy. If you find a lesion, know the clinical spectrum. What is leukoplakia? What is erythroplakia? What is mixed lesion? Be able to perform lesion assessment. That means doing a biopsy or using the adjunct in a way that you know how to interpret. Remember, when you get out, there is no boss there. You'll be your own boss. Your conscience is your boss. You'll be the one who decides what's better for the patient, and you really need to educate yourself. And the concept of lifelong learning comes into play. You have to take CE courses. You have to kind of educate yourself to do the best thing, best option for the patient. My goal thing is that if I don't feel comfortable with something, I always refer. I tell the patient, I apologize, Mrs. Jones, this is not what I'm good at. I'm good at this. If you need that, I'll be more than happy to do it. But I know somebody that will do a fantastic job for you, and I make the call. And that way, patient appreciates that. You know your limits. No, an expert for discussion and referral, low threshold for referral. Don't say, oh, it's nothing. It's their life. It's their mouth. You cannot dismiss it or, belittle it. And show the patients how to do self-exam between visits. They come to see you every 6 months, but between every 6 months, they can do the self-exam. It's very easy to do, and there are several steps. Patients can palpate, they can actually feel. Every time after I give these lectures, people catch me in the hallway and I say, I have this lump here. So, people can do that. And then they can reflect their lips and check this. They can look at the visible area of the tongue. So self-exam is possible. And if they have a sore that doesn't resolve, they don't have to wait till the next visit 6 months from now. They can come sooner. And I think you've heard enough of it. Thank you.
Yeah. This is mine. No, I'm scared.
You what?
Scared.